Okay, let's get started, everyone. Thank you for joining us today. We are here to celebrate Women's History Month with a special panel discussion about women's health in relation to tennis. I'm Alex Wesley, the Director of Marketing for USTA New England, and I'm joined by three esteemed doctors from orthopedic and neurosurgery specialists, our exclusive orthopedic partner. ONS is a top 5 orthopedic center of excellence in the nation, and we're happy to have them with us today, so thank you for joining. The agenda today will start off with presentations from each of our doctors, and then we'll open this up to Q&A. So please feel free to type in your questions into the chat throughout the webinar. All of your questions will be anonymous. Now, I have the pleasure of introducing you to our first speaker. Dr. Megan Gleason is a board-certified orthopedic surgeon who specializes also in sports medicine. Her practice focuses on the diagnosis and treatment of activity and sports-related injuries in the knee, shoulder, and elbow. She's worked with many sports teams over the years, both at the college and high school level. She's talking to us today about common shoulder injuries in tennis players, the causes, symptoms, and how to get back on the court. So with that, I'll pass it to you, Dr. Gleason.
Okay. Good afternoon, everybody. Hopefully we're all set. So I am an orthopedic surgeon. I'm hoping that most of you will come see me, but not need to go to the OR with me. So we'll talk a little bit about some of the common things that I see, the things that do unfortunately sometimes end up in the OR, and maybe some tips on how we can avoid problems down the road. So today I'm going to talk very briefly about shoulder anatomy, and then I'll talk a little specifically about the shoulder as it relates to tennis specifically, what you can expect if you come into the office for evaluation, common things that I see in tennis players, so symptoms that you might report, and then what some of the treatment options are, obviously operative and non-operative. And then we'll touch just a little bit on injury prevention. You'll hear a little bit more about that from some of my colleagues as well. So we'll talk a little bit about the shoulder anatomy. So this is oftentimes what we refer to as a ball and socket type of joint. We have the humerus and the glenoid, or the ball and the socket. It's not as simple as just bony structures, though. The shoulder is a very complex structure in terms of the ligaments, soft tissue, cartilage, and muscles that surround it. This view on the left side, we're seeing a little bit of what we refer to as the labrum, which is the bumper between the ball and the socket. So we're looking at that shoulder kind of face on. And then on the right side, we're seeing some more of the ligaments that surround and support the shoulder. The shoulders we'll talk about more as a very mobile joint. And so there's a lot of things, unfortunately, that can go wrong depending on what you're doing. In addition, we see muscles, capsule, we see this different joints, we see bursa. These are all structures that we're going to look at when people come in with shoulder pain. The most notorious part of the shoulder is going to be the rotator cuff. Not every shoulder injury is a rotator cuff tear or a rotator cuff problem, but that is probably the most common that people will refer to most frequently when they're coming in. They come and say, oh, I'm really worried there's something wrong with my rotator cuff. The cuff is a series actually of 4 muscles that then become a tendon that inserts on the bone. So it's not just one structure, even though we refer to it as the cuff, it's actually 4 separate entities, and we do want to always assess those 4 separately. So shoulder as it relates to tennis, as I said before, the shoulder is a very mobile joint. It moves in just about every direction, which allows you to go overhead for serves. It comes, your forehand, your backhand, you can move in many, many directions, which is obviously very important. But when we think about motion, we also want to think about stability and also power. And when you're thinking about optimizing your tennis game, all of these are very important to consider. In addition to just the ball and the socket, we also have to think about the shoulder blade or the scapula and how that moves and supports the shoulder joint. Talking more specifically about tennis, when we think about serving, you generate a lot of force through your legs and your hips and kind of coming up into your torso, and then it's going to come through, it's going to be delivered through the arm, the shoulder, the elbow, the wrist. And so unfortunately, as we move kind of down that chain, what's at the end, so the wrist, the elbow, and the shoulder are going to be more susceptible to issues. So if you think about what your follow through looks like and how you're hitting, that's where sometimes, you have to work a little bit more on your mechanics. So things that we're thinking about specifically in tennis players. What does your overhead motion look like? Okay, how repetitive are your activities? How often are you playing? How long duration are you playing? And then obviously the dynamic motions of what does your forehand look like? What does your backhand look like? You need to have stability around the shoulder to try to prevent injuries. You also need to, and I don't mean coordination, like are you coordinated or klutzy, but more of the sense of how are those muscles firing together? Are they working together, or is one really strong muscle kind of over dominating the shoulder? And are you relying too heavily, or compensating is a word that we often use. So we want to think about muscle balance and coordination of muscles, and recruiting all of these muscles together to really give you the most power when you're trying to play. With power comes strength, so how strong are you? Are you working specifically on strengthening and balancing out muscles? And if so, like, how can we use that concept to prevent injury? So shoulders bothering you. And this little picture that I put down on the right side is what I often see. People come in, they're grabbing right in that one spot saying, my shoulder hurts, my arm hurts. Sometimes it's hard to differentiate. Is it the shoulder? Is it the arm? But that grabbing of that structure kind of right on the side is oftentimes what people will come in complaining about. We always want to know, where is your pain? When did it start? What were you doing when it started? Was it a sudden onset, or was it something that gradually got worse over time? Do you have pain at night? That's a question that we will always ask, and hopefully you'll share with us, because that'll kind of dictate some of the directions that we can go with in terms of treatment. We always want to examine our patients. What's your motion look like? What's your strength? What's your function? Again, where is that pain? And then there's certain maneuvers that we can do that really help us localize, where is the pain coming from? Is it one of those 4 rotator cuffs? Is it your labrum, that bumper between the ball and the socket? Is it really more your bicep? Is it your shoulder blade? Is it coming from your neck? We'll go through all of these different things to try to figure out the culprit for your injury. X-rays are often very helpful in just getting a layout of kind of what the joint looks like. And then we talk about some of the initial treatment options depending on where your pain localizes to. Do we have to shut you down? We try not to. Obviously, people who love to play, they don't want to be told that they can't play anymore. So is it just a modification? Do we let you play less? Do we change how you play? Do we start you on some medication? Sometimes that's a very personal decision, what's appropriate for each of our patients. A mainstay of what we do, which Alicia, one of our speakers, will talk on a little bit more, is the physical therapy element. That is really critical, going back to that muscle balance coordination element. And then, do we need more imaging? We often don't start with an MRI, but it is something that we consider if you especially are not feeling better over time, or you're not seeing improvement. There are some circumstances where we will get imaging right away. But again, we often try to treat this conservatively, because a lot of these injuries can get better without going down the surgical road. So some common things that we're just going to run through. I'm going to talk a little bit about bursitis, impingement. Labral tears are often referred to slap tears, bicep tendonitis, and rotator cuff injuries. You can also fall and break things. You can also fall and dislocate or separate your shoulder. I'm going to leave these more that's a different talk on a different day. We're just going to go through some more of the mainstay that we see frequently in tennis. So a common theme as I run through these different types of injuries is that they're very similar in their initial presentation. You're inflamed, you're irritated, certain motions really hurt, and you hurt at night. That tells me that shoulder is unhappy, it's irritated on the inside, and these are the common complaints that we'll hear. Just coming in with some of these, obviously you can't really differentiate between the different types of diagnoses that you may get. And so that's where the examination and a little more intervention can be helpful. I'm going to group labral or slap tears in with the bicep, and I'll show you that on a different slide, of more of an illustration, to show that these often do go hand in hand. It's often pain right in the front of the shoulder. Sometimes it radiates down into your bicep, trouble moving away from your body or overhead, and again, that pain at night symptom. Rotator cuff could be a little bit more variable. Again, we're working with different muscles and tendons, so depending on the location, similar symptoms can occur. Treatment. We always, again, start with some non-surgical options. It's very rare, and we don't really want to rush you to surgery for something that's going to heal on its own. So modifying what you do, using ice and heat, maybe some anti-inflammatories like Advil or Motrin, maybe some Tylenol if that's appropriate, using physical therapy, stretching, flexibility, strengthening, working on your mechanics. Sometimes there's a place for cortisone or steroid injections. That's a very it's a topic of debate among certain providers. There is a role for it still within orthopedics, but it's not just something we want to just start putting medication in without really considering what your diagnosis is. So just to run through some of these, bursitis. So that's inflammation within the shoulder. On the left side, you're seeing what a healthy bursal tissue. It's kind of a fluid-filled sac. When it gets inflamed, it can really hurt and it can cause a lot of pain. This is usually something that gets better with activity modification and conservative treatment. Very rarely does it become surgical. There is a role for cortisone injections in people with bad bursitis. This can be done under ultrasound, which we show down here in the picture. If you're going to have these injections, your provider really should be wearing gloves. So this is a bad picture for this. But that is something that, and a place where that could be appropriate. Impingement, that's a word that often gets thrown around with shoulders, and that's basically a pinching. So if you think about the structures on the left side of the screen, as you bring your arm up and you go into motion, sometimes the structures can get pinched or collapsed within the joint, and that can also cause a lot of pain and inflammation. Usually, again, that can get better with activity modification, some therapy, bringing down the inflammation. There are some circumstances where we need to create more space. And the pictures down here are showing what we call a decompression, where the picture on the very left side is showing where it's a little tight in there. We use a little burr, as we refer to it, that is going to create more space and open up the bone so that the structures don't get pinched. The bicep. This is a very common injury between the bicep and the labrum that I will see in any kind of overhead athletes, but oftentimes in tennis players. One of your two bicep tendons runs right across the front of the shoulder, and it's very prone to getting inflamed. That tendon actually dives deep into the shoulder and attaches to the top of your labrum. So if the labrum gets injured, you can get bicep symptoms, or the bicep can be on its own injured. So they often go hand in hand, and they're often treated very similarly. But this is a classic, very front of the shoulder pain that sometimes runs down into the bicep muscle. We try to treat this also conservatively with our initial activity modification, stretching exercises, using some anti-inflammatories. This is a place that sometimes we will do cortisone injections around that tendon where it gets irritated. Unfortunately, when people don't respond, this is something that sometimes requires a cleanup, and then we can move the bicep tendon. We can tenodesis, where we reattach the bicep to give it more stability and take care of that shoulder pain. And then finally, that notorious rotator cuff. So the rotator cuff is a stabilizer of the shoulder. It can get tendonitis, or it can get irritated. It can also tear. Oftentimes with tearing, some of the tears may heal on their own. A lot of them do not and do need surgery. So we can kind of guide you through the different stages of that depending on what your symptoms are. Once again, therapy and anti-inflammatories are helpful. Cortisone injections are a topic of debate around rotator cuff injuries, but sometimes appropriate. And when they don't heal, we talk about repairing it. So these are some pictures of what a rotator cuff repair may look like. The left side being an illustration, the right side being an intraoperative photo. Rotator cuff repairs are notorious for taking a long time to heal. It's not a 6-week turnaround. It's usually 6 to 8 to sometimes 10 months of recovery. So it's something, especially for active people, we want to try to avoid this being surgical, but at the same time, unfortunately, these don't always heal independently. So tips for prevention. Ramping up slowly, so as we come into the spring season, you're getting outdoors, maybe you didn't play much over the winter. You don't want to go consecutive days, 4 days a week or 5 days a week. But as you build into it, you get some strength back, you get, your rhythm back in terms of how you play, you can start to play more often. Warming up and more of a dynamic stretch can be very helpful. Paying attention to strengthening and that muscle balance is also really important around the shoulder, and talking about that mobility and stability concurrently. Got to think about overuse. If you go out and you really want to work on your serve and you're out there for 4 hours serving over and over again, I worry that you're going to run into some trouble with that shoulder. So, paying attention to your timing can be really helpful to prevent overuse type injuries. Using proper equipment, the racket's appropriate for you, the size, the weight. Thinking about your mechanics. So this is where coaching and clinics can come into play and can be very helpful to make sure that your mechanics are good and that you're not putting yourself at increased risk. This is a great resource for people who have more questions about their shoulder and could possibly, not that we want you to necessarily self-diagnose, but if you're thinking about some of the symptoms you may have, this is our Academy website, and you can go onto the Ortho Info website and click on different parts of the body. And this is for not just shoulder, but hip, knee, back, and it can give you some very specific information about either symptoms that you may have, or if you have a diagnosis and you're wondering what you should do next, this is a great resource. And with that, we'll turn it over.
Thank you so much, Dr. Gleason. Next up is Dr. Eliana Cardozo. She's a sports and spine physician who specializes in the non-operative treatment of musculoskeletal conditions. Dr. Cardozo treats a wide variety of conditions such as tennis elbow sprains and arthritis in athletes. She is board certified in both sports medicine and physical medicine and rehabilitation. She'll be talking to us today about lower back and elbow injuries in tennis players. Thank you for joining us today, Dr. Cardozo.
Hi, thank you so much for having me. And so, sorry, 1 second while I open up my screen here. So I'm a physical medicine and rehabilitation physician, and I specialize in sports medicine and interventional spine. So let me just make sure I am sharing here. Okay, here we are. All right, so we're going to start off talking about low back pain. So low back pain is extremely common. Over people's lifetime, about 80% are affected. And in the athletic population, it's even higher than that. About 85% of people are affected. So tennis is a very core heavy sport. There's a lot of trunk rotation. And then with serving, especially, there's a lot of hyperextension and trunk rotation, which can put some stress on the back. So we do run into low back pain quite a bit. So as far as causes of low back pain, there's a few different ones. So the most common being a muscle strain. So as far as symptoms, usually this presents with more pain localized to the low back. It's not radiating into the legs. There's no neurological symptoms like numbness and tingling or weakness. As far as diagnosis, usually getting a good history and physical exam. Usually on our physical exam, the person might have some tenderness to palpation over their low back, but their neurologic exam is completely normal. As far as treatment options, so activity modification, meaning I usually tell my patients, listen to your body. If something hurts, don't do it. And then medications really are for pain relief. So something like acetaminophen, or sometimes we do use non-steroidal anti-inflammatories like ibuprofen or naproxen. And then physical therapy is extremely important, and it plays a big role in both improving the muscle strain that's there and also preventing future issues with the back. Because once your core stabilizers are as strong as possible, you're going to be in much better shape. But you'll hear more about that in a little bit. So other causes of low back pain, so disc issues. So this is a close-up of the spine here. So these bones are called vertebral bodies. They stack one on top of the other, and in between we have our discs. So I like to think of the disc like a round, it's going to sound funny, like a round jelly donut. So the outside has a fibrous capsule, the inside has a gelatin inside. And so different things can happen to the disc. One being disc degeneration. That's when some of the hydration from the disc is lost and some disc height is lost. That can cause pain in the back. We call that discogenic pain. Sometimes part of the gelatin from the disc can come out. That's called a herniated disc. You might have heard of different names for it, like a slip disc. When that gelatin comes out, the structure that lives adjacent to it in the spine are the nerve roots. And in our low back, those nerve roots go on to innervate different parts of our legs. So many times disc herniations can cause nerve root irritation. So that you might hear someone call it sciatica, but it's basically low back pain that runs down into the leg. If someone's presenting with that, they should definitely see their physician for evaluation. As far as diagnosis, we usually start with a good history, a physical exam. Physical exam is very important once that nerve is irritated, because we want to see, is there any muscle weakness? Sometimes it can be very subtle. Are there any changes in reflexes or in sensation? And then usually there is some imaging warranted. So we start off with lumbar x-rays to see more the alignment of the back. Depending on the exam, we might need further imaging, such as an MRI of the lumbar spine, to see the nerves and discs. But it really depends on how the person is doing and if they have any neurological changes on their exam. As far as treatment options, so again, the mainstay of treatment is going to include physical therapy, core stabilizing. There's some specific types of therapy for that nerve irritation that work well, and then medication. So for medications, it really depends on the person's pain level, what we use. There's different options. The first being just regular analgesics like acetaminophen. There are prescription strength anti-inflammatories. So those are the same class as ibuprofen or naproxen, which are like Aleve or Advil, but stronger. And then there's also oral steroids that we use in certain situations. In addition to that, there's some nerve pain medicines that can be used, but everything comes with, risks and side effects. And it really depends on the person's history. If they have other issues like diabetes or high blood pressure, that comes into play as well. There's also injection options for irritated nerves. So there's something called an epidural steroid injection, which is under X-ray guidance. We go to that nerve that's irritated and bathe it in a steroid medicine to calm down the pain and inflammation. If all of that fails, or if the person is having severe neurological changes, then there are surgical options to decompress the nerve as well. Other causes of low back pain include arthritis. So just like you can have arthritis of other joints like your knee or hip, your back also has joints that can have arthritis. So the little joints in the back, the posterior part of the back, are called facet joints. So they're tiny joints, but they're true joints with a synovial capsule and everything. And they can get arthritis and become painful. So again, the diagnosis is very important to see a physician, get a good history and physical exam. This type of arthritis pain is usually more with extension of the back because that really is what stresses those little joints. And so there's different exam maneuvers that your physician might do during your exam to see if that's what they think you have. As far as treatment, and then of course imaging. So usually start with x-rays. If you don't improve with conservative treatment, then there's other imaging modalities we use. As far as treatment options, so you see a lot of physical therapy in here because it's just very important. So the physical therapy in these situations sometimes has to be modified so that the exercises are not painful. And that's very helpful because then they can show you how to stabilize your core without exacerbating your pain. Medications similar to the other conditions, so analgesics like acetaminophen, anti-inflammatories. And then there's different types of spinal interventions for this issue. The most common being where we ablate the little sensory nerves that provide sensation to that facet joint so people don't have pain. Now we're going to switch gears and talk about the elbow. So another very common ailment in tennis players. About 50% of tennis players will get this at some point. So lateral epicondylosis. It's basically a degeneration or wear and tear of the tendons on the outer elbow. So these tendons are the ones that help our wrist extend up like this. The most commonly affected tendon is the extensor carpi radialis brevis. Back in the day, we thought it was more of an inflammatory condition, but now we know that it's not, usually doesn't really have inflammation to it. It's more degeneration and micro tears. So as far as causes, number one cause is overuse. Much more predisposed to this if the person is playing more than 3 times a week for more than 30 minutes at a time. The other factor is poor mechanics. So leading too much with your elbow during your backhand, repetitively extending the wrist during backhand, and also thinking about your grip strength. So there's been studies that show that players that keep a strong grip strength throughout the entire backhand stroke are more predisposed to this, as opposed to players that have strong grip strength, but then in the follow-through phase, they relax the grip strength a bit. So that's where coaching, working with a like tennis coach can be very helpful if you suffer with this. So diagnosis, again, a good history and physical exam. This is a very clinical diagnosis, meaning the physician can, figure it out from your history and physical exam. Imaging is kind of just a plus, but basically the person usually has tenderness over the bone where those tendons attach, called the lateral epicondyle. They will have pain with resisted wrist extension, and then on imaging, you usually get x-rays first to see if there's any underlying arthritis in the elbow joint. You can also see if there's any calcifications of that tendon. You don't necessarily need more imaging than that, but if you're worried about a partial tear, so like a larger tear than a micro tear, you can see that with an ultrasound or an MRI. As far as treatment, usually treatment for this is conservative. People do really well. The first thing is rest. So, you want to take down that offending activity. Physical therapy is very helpful. It's an eccentric type strengthening program, which we'll hear about more a little later. There's some bracing options for this. So there's an elbow strap that you can wear that offloads some of the tension from the outer elbow. And then there's injection options. So for this condition, steroid injections has been shown to help really short term, But in some certain cases, that might be helpful. Someone, is in terrible pain, they're not sleeping. Every patient is like an individual case that you have to take a case by case basis. There's also options for different injections, like something called platelet-rich plasma, where we take your blood, we centrifuge it to concentrate the platelets, which have cytokines and growth factors, and inject it back into the tendon. And if there's a partial tear, we inject it into that area. And then if everything, if the person is not improving with conservative treatment, there's also surgical options. Now I'm going to talk about the opposite. So medial epicondylosis. So it's basically what you are feeling on the outer elbow, but this time it's on the inner elbow. This one, instead of tennis elbow, you might hear golfer's elbow. This is much less common in general, but also much less common in tennis players. And it's basically wear and tear, degeneration of those tendons that attach to that inner elbow, the medial epicondyle. And those are your flexor tendons that flex your wrist. So your pronator, forearm muscles. So these people may have pain during their serve and forehand strokes. Again, some of it is overuse. Some of it might also be not great mechanics. So if you're getting this recurrently, you're going to want to take a look at your strokes. And then as far as diagnosis, so again, a really good, like it's always the basics, right? Like a really good history, a really good physical exam. The person usually has tenderness over that medial epicondyle. They might have pain with resisted wrist flexion. And then as far as treatment options, avoiding the offending activity or at least taking it down a notch. Physical therapy is very helpful. And then injection options for this are very similar to the outer elbow, as in steroid, again, short-term relief, but for some people that might be helpful. And then there's the platelet-rich plasma options as well. And if all of that doesn't help, then there's surgical options. So, it's like a tiered approach that we use in medicine, with the most conservative things first. And that's all I have for today. Thank you.
Thank you so much, Dr. Cardozo. Tennis elbow and low back pain are so common with tennis players, so we appreciate you sharing your expertise on that today. We do have questions coming in that we'll get to at the end, so here's your friendly reminder to type in any questions that you may have in the chat box. Again, those will be anonymous. And our last presentation today is about bringing your A game, training for the female tennis player from youth to adult with Dr. Alicia Hirscht. Dr. Hirscht is the Director of Physical Therapy at ONS Stanford and began her career at the University of Chicago Medical Center. There, she practiced with leading physicians and researchers in the field of sports medicine. She lectures regularly on injury prevention, adolescent sports medicine, and women's health. She's board certified by the American Physical Therapy Association and serves as a mentor and clinical instructor through the APTA. Take it away, Dr. Hirscht.
Good afternoon, everyone. Thank you so much for attending. I just wanted to share personally that while I'm also a sports physical therapist and I see a lot of tennis players, I have 3 children aged 10 to 15 who are on the USTANE New England circuit, and their father is a tennis instructor and he runs an elite junior program. So I feel like I eat, sleep, and breathe tennis training and injury prevention. So hopefully I can impart some great wisdom here, and then we'll go through all the exercises and talk a little bit about what Dr. Cardozo and Dr. Gleason spoke about with shoulder injuries and back injuries, and how we can hopefully prevent this for both some middle-aged folks who might be in attendance, but also the young females like my 15-year-old daughter. So causes for injuries during racket sports, we've already heard mostly about the shoulder, elbow, and back injuries, but we can go into the logistics of every little injury. But when you really zoom out, the biggest cause that I see in my tennis players, female tennis players age from young to older, is that we have generally a sedentary lifestyle, which leads to a lot of imbalances in stability, instability, tightness, weakness in our core, in our shoulders, in our legs, like Dr. Gleason was touching on earlier, improper conditioning. The biggest thing I see is that we sit all day and then or maybe not all day, but then we sit for the most of the day with our work and our schooling, even our younger athletes, and then we go out to the tennis court and train for an hour or 2 in a clinic or private, and we don't really properly warm up, or we don't necessarily have the background conditioning that we need. And that's where the muscle imbalances lie. One thing that professional athletes do is they train all day in order to play tennis. And then the rest of us non-professional athletes are using our tennis oftentimes as our fitness and our training. And that's a point that I tell all of my patients, if you want to play tennis, whether it's at a USTA level or even just local club D team, you have to condition properly, and you have to be aware of your posture, and we have to address those musculoskeletal imbalances in order to make you a better, safer, healthier player. I'll touch a little bit about equipment issues towards the end of my talk. I am going to focus more on the exercises to help address the impairments that we see and the conditioning that we need. So the racket sport biomechanics, we can again go into each individual joint. In particular, tennis, more than probably any other sport, works you from your toes all the way up into your shoulder, wrist, and neck. And the gist of it is there are rapid accelerations and a lot of changes of direction. Let's look at a tennis serve like in this picture. We start pretty neutrally standing, and then, as most of you have served several times in your career, we start to lean back, we start to bend. We're opening up in the front of our bodies, our hip flexors, our quads, our abdominals, the front of our shoulders, our pecs, our elbow, all the way up to our wrist, and we're generating a tremendous amount of force in those muscles in the front of us that are also potentially tight from our more sedentary lifestyle and our work environments throughout the day. Then those muscles generate a tremendous amount of force to hit the ball where we need to hit it, right, with great velocity and great accuracy. After we've made contact with the ball, the reason our tennis racket doesn't fly out of our hands and our shoulder doesn't fly out of our socket is because all of the muscles on the back of our bodies now, so we're talking about the deltoids, the spine muscles, our hip extensors, our hamstrings, those muscles produce a tremendous amount of force to decelerate our body so we don't fall flat on our heads, and then move us to where we're going to return the ball again. So there's a lot of forces on what we call the posterior chain, which is the back of your shoulder, your back, your hips, your hamstrings, to absorb the force that you're producing when you swing your racket, when you serve, when you forehands and backhands. There's a lot of training that goes into keeping these muscles healthy and avoiding injuries. We've already discussed at length the common types of injuries, obviously shoulder tendinopathies, impingement bursitis, elbow issues, back strains. I am going to touch on exercises for calf and hamstring strains and Achilles ruptures. We do see a lot of popped Achilles, unfortunately, in our tennis players. But again, there are exercises in my presentation to address this. And again, all of these injuries are usually because people are not necessarily in the best optimal condition. They're not necessarily warming up. They're maybe not using the right tension in their strings or the right size racket. And we'll talk about that more at length. So I do want to go right into the exercises because this is the nuts and bolts of my presentation. There's so much evidence to support how important it is to do rotator cuff work, what we call posterior shoulder work. Here on the left side, you see a standard. This is my colleague. We went to a tennis court. We grabbed a long TheraBand from the clinic, and we took these pictures. You can set up a band in the fencing as we have done here, or you can do these exercises at home. As a general rule of thumb, we like to do injury prevention exercises for tennis players at least 2 to 3 times a week so that you're conditioning and training in order to play tennis healthily. So we basically call this external rotation. Working your external rotators is key to keeping your rotator cuff healthy to avoid those impingement bursitis, tendinitises, and slap tears. So essentially, you keep your shoulders back, you're rotating your arms up. The same position of the band, you start with your arms in front of you, you pull back, that's an exercise on the right. And the same the band in front of you, you start holding the band in front of you, you pull back and you squeeze your shoulder blades. These 3 exercises are key to making that posterior shoulder and your upper back strong to absorb those forces every time you hit that tennis ball. Here's a couple more shoulder exercises. This one on the left is a common exercise we use in the clinic. It's called the Y exercise. If you see from the wrist all the way down to the mid back here where her sports bra is, there's a line of muscle there, the lower trap, the serratus anterior, posterior cuff. All of those muscles are on super max overload with a tennis server and overhead, for example, and those muscles are pretty weak, mostly again from improper conditioning and or sitting at work, in the office, doing the thing, driving, doing the things that females tend to do. And doing this Y exercise, 2 sets of 15, 3 times a week, has been shown in the evidence to prevent injuries to the rotator cuff and the shoulder. This is a basic punch out exercise. So there we're, again, using the same one long band and just lifting up and overhead and punching through our shoulder blades. That's helping to strengthen the front of our shoulder, those muscles that produce the force to swing a racket. Exercises to address tightness. So again, because we are not necessarily conditioning all day in order to play tennis like the pros do, we want to address some of the tightness that goes along with, you know, being a student sitting at a desk all day or working at a computer all day. Basic corner stretch opens up those chest muscles, those pec muscles. This one down in the corner, left-hand corner, this is what we call a posterior capsule stretch. This is a great way to stretch out your rotator cuff, both before and afterwards to help prevent injuries to your shoulder, and then a basic tricep stretch. With most of you, if you're playing tennis on the USTA circuit, all of these stretches should be familiar to you. Injuries to prevent the wrist and elbow. So I do find that more now than ever in my 20-year career, women who play tennis are conditioning a little bit more regularly, but there's a lot of Pilates, there's a lot of yoga, there's a lot of core, spine, hip and leg work, which is tremendous to prevent injuries. But we are often forgetting the elbows, the elbow work and the wrist work, and a couple of basic exercises with a 2 or 3 pound weight, a heavy water bottle. Everybody carries water bottles with them when they go to their tennis clinics and their tennis matches. If you want to help prevent that the tennis elbow pain, the medial elbow pain that we just learned about, these wrist curls, and then working your arm from palm up to palm down motion. Wrist curls, both extending your wrist where your palm is facing down, and then you flip your arm over and you curl your wrist. So you're working both sides of the elbow, and then moving the dumbbell from palm up to palm down. These 3 exercises in the evidence have been shown to prevent injuries in tennis players. A lot of this gets neglected in our basic everyday conditioning and gym workouts. Again, basic 2 to 3 pound weight or a heavy water bottle, and this will help prevent those tennis elbows. Basic extensor stretch, basic wrist flexor stretch. After you do your workouts, you can stretch out those muscles. I do recommend I'm going to take a moment here. This program should be done as a conditioning program 2 to 3 times a week. These stretches should be done as a part of this program. A lot of people, when they get to the tennis court, start with stretches like this. As a global recommendation, I would say you don't want to start with any stretching. If you just think about what you're doing to your muscle and your tendon tissue, you're actually lengthening it, you're dampening the circuit, but then you're about to go play a clinic or you're about to go play a match. We want to, if anything, do a more dynamic warm-up, grab one of those light bands that you have lying around the house, do some of these exercises that I've showed you already. I save the stretching for afterwards. I don't have my patients or my tennis players stretch beforehand. When we talk about the back and hip injuries, there are a lot of exercises out there for back and hip. And when I see patients specifically with an injury in the clinic, we're going to do a lot more thorough and comprehensive exercises than these. These are just a general progression. And if you work with your coach or your trainer, or you're working with someone at the gym, again, there's a lot more that you can do. But in the interest of time and also a good basic program for people to start with, these are what we do: planks and side planks. So you can see on the bottom left, you're just getting on your forearms and your toes to keep a nice long line like this. You got to keep your glutes, your buttocks squeezed, your tummy tight, your shoulder blades pinched. Hold for 30 seconds. And then on the side, you can hold or you can lift your hips up, which is makes it a little bit more dynamic. And then we're working all of those muscles on the side of us, which are so important for the lateral movements. The thing I love about planks is that you are literally working your wrist all the way down to your ankles and your Achilles. So with just these 2 exercises, you're getting a whole body workout. Back and hip injury prevention, again, basic squats, basic lunge squats. Again, if you have a big water bottle, you can use that as resistance. If you have weights at home, you can use that as resistance. Bottom left is just a basic squat. We see our back is kept in neutral. Our shoulders are back. We don't let our knees go past our toes, just basic squat. And if you have a weight or a medicine ball in front of you, that's where you hold it to help train the core to get ready for like when you're using a tennis racket. Same thing with lunge squats. You can start standing your feet together, take a step backwards, lunge down, or take a step forward, lunge forward. In this picture, she has dumbbells in her hands. You can add dumbbells. You can add a medicine ball at your waist. You can even add a twist to this, which is a little bit more sport specific for tennis. Lateral lunges and a single leg deadlift. I love lateral lunges because obviously we move laterally. You can, again, add weights, add medicine balls. If you're working with a trainer or a coach specifically, you can make this more sport specific when it comes to tennis movements. A single leg deadlift is probably one of the most important exercises you can do to avoid hamstring injuries and Achilles injuries, specifically on patients who serve. Most tennis players are right-handed players. That means you're coming down on your left leg after every serve and every overhead. That left leg is going to absorb that shock. The glute and the left glute, the left back, the left hamstring, the left Achilles in right-handed tennis players tend to be the most injured. And something like this in your everyday workout will help prevent that. And in here, she's just using probably a 5 or 10 pound kettlebell. You start standing, you lean forward, you keep your back straight, you keep your tummy tucked, and then you come back up. And here's our dynamic stretches for our hips and our back. I mean, again, I don't see too many players when I go to my kids' clinics and tournaments actually stretching on the tennis court. But if you happen to be playing in the community, this is a great way to just incorporate where you are and what you need to do to stay fit and healthy. But that first one here is a hamstring stretch, and then we have an inner thigh groin stretch, a little figure 4 or deep piriformis hip rotator stretch there. She's got her leg up and she's resting her foot and ankle on the bench there, but that was courtside. This top one's called a press up. Hyperextension is a source of back injuries sometimes, like Dr. Cardozo spoke about, but in general, most tennis players, and especially most middle-aged female tennis players, are very tight in their abs and their hip flexors. Again, most likely because of the more sedentary lifestyle and the office work that we do most of the day. So doing something where you actually lift your head and shoulders up, keep your hips flat, is a great way to release the abs and the hip flexors and decompress the back. And then bottom right hand corner is a basic hip flexor stretch. And then for ankles and Achilles, again, there's a tremendous amount of evidence that shows just a basic heel raise, but off the edge of a step. I don't know if you can appreciate this, but on the right side here, my colleague is lifting up onto her toes. So she's working her calf and her Achilles tendon, but she'll let her heels come down even lower than the edge of the step. And that trains your Achilles in an eccentric way, which is what we need in order to prevent injuries and popped Achilles and those calf strains. And then on the left is a basic calf stretch. Minimizing other risk factors. So a lot of people ask me about, what a proper warm-up is and what a proper cool-down is. And I've touched upon that about midway through. A warm-up, you can take this entire program, dumb it down, and just do 5 reps of each exercise, right? You do a little bit of rotator cuff work with your band. You do a little bit of ankle raises. You do some lunges, some squats. An active warm-up, if the tennis center that you're training at has a bike or a fitness room, you can get on a bike and warm up for 5 to 10 minutes, especially if you're going to your clinic or your matches after you've been sedentary most of the day. It's called a warm up because we're trying to loosen up our muscles, create heat. And so an active warm up would involve exercises. A cool down is what you do afterwards, which is the stretching that I highlighted in this program. In general, if we want to be conditioning properly, we want to be doing 30 to 40 minutes of cardio 2 to 3 times per week. That can be SoulCycle, that can be running, jogging, it can be whatever you want, but we do for general fitness, heart health and cardiovascular health, but also in order to continue to play tennis matches and clinics without getting hurt, you should be cardio training regularly. And then strength training, like something we just reviewed this whole program, at least 2 to 3 times a week. Proper form during strength training, I mean, that's kind of a no-brainer for people who aren't sure what proper form is, or they're just starting from ground zero. That's when working with a trainer and or coming into PT at some point, that's where that could help. Functional strengthening related to the sport, like we talked about in the presentation, you could do lunges with some rotation, which will bring in, there's so much rotation in tennis. Nutrition and hydration, that itself could be a whole another talk, but obviously you want to stay hydrated, and not just during your clinics or your matches, but throughout the day, both before and afterwards. And I do want to just talk about appropriate shoes. I don't necessarily have a brand that I recommend, but I do think any female tennis players out there that might be playing through or with tennis or with knee pain, you might want to consider getting fit with proper shoes. You might want to consider orthotics, maybe speaking to or going to a gut reaction or a tennis shoe store where they actually are experts and they can answer and measure your foot and look at what the best one, what the best brand might be for you. And that's about it. Oh, I do want to say though, this program is appropriate for, someone my age, middle-aged tennis player, but it is also appropriate for the younger athletes. I would have my daughter who's 15 do all these same exercises. The difference between a 15-year-old or a 12-year-old female athlete versus a 40-year-old female athlete, I will say, the underlying concept is younger tennis players tend to get injured because they're just ramping up too much too soon. And that's where we tend to see some of the stress reactions and stress fractures and things that shut them down. As a general rule of thumb, younger tennis players can do this entire program healthily. It will help prevent injuries in them too, but younger tennis players should not be playing through pain. That should be addressed and seeing a doctor immediately. And then also with all female tennis players, try not to ramp up too much too soon. And that's my general rule of thumb. Thank you.
Thank you very much, Dr. Hirscht. Love that you have a tennis family too, by the way. And thank you to those who submitted questions throughout the webinar. We're going to spend the next few minutes asking the doctors those questions, so feel free also to submit them now. We're monitoring the chat box. So the first question is actually for you, Dr. Hirscht. What is the starting position for the Y exercise you showed us?
Just feet hip distance apart. The band is anchored in front of you about chest height, like it would be for all of those other band exercises. And hopefully people can see me now, right? So you start with your arms in front of you about chest height, and then you're coming up and out so that you look like a Y from behind at the end of the repetition. And then you just come back forward. Thumbs back.
Great, thank you very much. This one, open floor for any of the doctors that want to answer this one, but what do you think of acupuncture as a treatment for shoulder pain?
Oh, hi, I can answer. So I think acupuncture is a great adjuvant for any kind of pain issue. There are some studies showing that it helps with pain in general. I wouldn't do it instead of something else, like instead of getting evaluated by a physician or physical therapy, but as part of a treatment program, it can be helpful.
And I will concur with that. I'm not a certified acupuncturist, but I do dry needling, and all of the clinicians at our ONS Stanford Clinic are all certified in dry needling. The approach is slightly different, or the theory behind it is different, but we do the same acupuncture needles. With a proper physical therapy program or conditioning program, sometimes those stubborn injuries just don't clear. And especially in tennis elbow and golfer's elbow, the medial elbow pain, I do find that doing some needle treatments to the stubborn tennis injuries are very helpful, in addition to the exercises and anything else the doctors might prescribe.
Great, thank you. That actually answers someone else's question that asked, what do you think of dry needling for calf treatment? So thank you for touching on that too.
Excellent for calf treatment. Excellent for calf treatment.
Great. I'm going to try to get this syndrome pronounced correctly, but is piriformis syndrome seen on tennis players? Besides ibuprofen, would steroids help with that?
I can take that one. Piriformis syndrome, for those that are not familiar with it, the piriformis muscle and tendon are kind of in your backside. So it's when you get a lot of pain in basically in your butt muscle. It's usually from a tendon or muscle group that's a little bit too tight, and it can cause a lot of pressure, and it can also compress the sciatic nerve a little bit. So sometimes we see people that have symptoms very similar to a sciatica, but rather than coming from the back, it's actually a little bit lower in the glute muscle, kind of in the backside. That is definitely something we do see in tennis players. Again, when we talk about hip tightness and the musculature around the hip, you're using those hips when you're playing, start, stopping, running, all of these things. So you can definitely develop piriformis syndrome. Ibuprofen is really helpful. Usually the mainstay of that is going to be working a little bit more on stretching and balancing out the hip musculature. So that's really, really important. We always talk about, Alicia showed that figure 4 position. That's a great stretch. And there's a couple of different ways that you can do that can be very effective. Steroids are helpful in certain situations. For people who can't take oral anti-inflammatories like Advil or Motrin, an oral steroid can be beneficial. There are some circumstances where we can do guided steroid injections, and I can defer to Dr. Cardozo about that a little bit better. It's not usually the commonplace or a mainstay of treatment, but it is an option to do some steroid injections into that area. There's some risks associated with it. It is an option, but it may not be where you want to start.
Okay, thank you very much. Next question is, I have a 4-month-old and got back on the court for the first time last week. I noticed that my pelvic bones feel loose when I pivot on the court. It's very uncomfortable, borderline painful. Would lateral lunges help with this, or what can I do to help?
Well, I'm just going to say that's amazing at 4 months postpartum that you're back on the court. So kudos to you. I, having had 3 babies myself, think that lateral lunges are great for for pelvic floor health and to eliminate pain. However, if you feel that unstable, you might need to start more basic. And so seeing a physical therapist who specializes in pelvic floor dysfunction, which we have 2 in our Stanford facility, just so you guys know, seeing either Dr. Gleason or Dr. Cardozo, I think that would be tremendous. Anyone who's had a baby and then also wants to play tennis should probably see a physical therapist, and especially a pelvic floor specialist at some point, because you really could do a little bit more damage than you realize. But there's so many exercises, really valuable exercises that you can do to get yourself back in shape and avoid future injuries.
Okay, great. Thank you. The next question is, I've had shoulder pain when serving for quite some time now. How do I know if I need to see a specialist?
I'm going to take this one.
Yeah.
I think a couple of things that when we try to decide when is it time to finally come in, I think number one is the duration of the pain that you're having. So if it's been, you just got back out there, you just started playing again, and it's been a little bit sore over the past, week or so, you can work through some of that. You can try to modify how you do things. You can stretch a little bit. If it's appropriate for you, take some anti-inflammatories and just kind of rehab yourself a little bit with some of the resources that were provided here. If it's something that's been ongoing and chronic, that's something where if you're changing what you do on a daily basis, you're avoiding use of your arm, you're not looking forward to going out and serving, that might be a reason to come in and to start to see us. If you're choosing not to play when an opportunity comes up because your shoulder is too sore, that's definitely a time to come in. And then the other thing that I mentioned a little bit in my talk as well is if you're having pain at night, like if your shoulder is sore, it's keeping you up at night, it's affecting your quality of life. Sleep is so important to me, so I know how important it is to sleep. If you can't sleep because you're having discomfort associated with that shoulder, that's definitely a time to come in.
Thanks, Dr. Gleason. Next question is thoughts on heat versus ice treatment. Seems like most therapists I know advise heat for muscular injuries, but most family doctors tell my students to ice.
I can take this one.
Yeah.
So I generally say if something is injured recently, say you like sprained your ankle or have a new injury, ice for the first 48 hours is what I usually recommend. The low back is special in that it can have some muscle spasm that does respond better to heat. So for low back, I usually, the actual recommendation from research is heat or ice, whichever feels better, or some people even feel better alternating. So that's usually what I know it's not a clear-cut answer, but that's usually what I tell people.
Thank you. And this will be the last question, so then we can wrap up after this one. Are there any anatomical differences between male and females that cause one to be more prone to a certain injury type?
I'm going to go back onto the anatomy side of things. Men tend to have a little bit broader shoulders, and in general, and I'm making very gross generalizations, so I'm not trying to get too much into the stereotypes, but men tend to have a more broadness to their shoulders and a little bit more of a muscular upper body. Some of that is developed intentionally. Some of that is just the way the muscles work and how they're built. From a bony standpoint, there's not a whole lot of difference, but I will definitely say from some of the supporting musculature, some men tend to have more strength in their upper bodies. A lot of women, on the contrast, though, have more flexibility. So there is a little bit of a difference in terms of some of the injury patterns we see. I see a lot of that bicep tendonitis in women. And I think some of that is because of the increased mobility and the decreased strength. For men, there are some variations that revolve a little bit more around the rotator cuff, and a little bit more of injuries that we see sometimes that are related more to like that really powerful serve. Not that a woman can't have a powerful serve, but there are some differences. And again, it's really breaking down that mobility versus strength balance.
Thank you, Dr. Gleason. Well, we've come to the end of our time together. Thank you all for spending your lunch hour with us and learning about these really important health issues as they relate to tennis. A special thank you to Dr. Gleason, Dr. Cardozo, and Dr. Hirscht for their time today. They all work out of practices within ONS with 4 of their 5 locations in Southern Connecticut. We'll send all of the attendees a follow-up email with the recording and then more information on ONS if you're interested. Thank you all for attending.